Yeah. We're going to get started in just a minute. All right. I'd like to welcome you to Columbia Ethics Grand Rounds. I am Sandra Sujin Lee, Professor of Medical Humanities and Ethics and Chief of the Division of Ethics here at Columbia. I am absolutely delighted to welcome you to today's Grand Rounds, which is entitled How an AI-Based Cardiovascular Screening Test Changed Care, a Million Results Late. For those of you who are new to Ethics Grand Rounds, this monthly series is organized by the Division of Ethics in our Department of Medical Humanities and Ethics here at VPNS. And the goal of Ethics Grand Rounds is to engage our community of health professionals, scholars, scientists, and trainees across career stages. We are focused on centering important topics and debates in medical ethics that relate to clinical practice, research, and education. And our hope is that you all leave each session with a greater understanding of the ethical and social implications of the topics that we discuss. This series is supported by a dedicated organizing committee of faculty and division staff for whom I'm very, very grateful. Before I turn to our topic for today, I'd like to remind our online audience to please check the chat for logistics and other information for this session. Today's session is going to be recorded and will be uploaded as a resource to the Columbia Division Ethics website following this event. Now, for today's Ethics Grand Rounds. Today's session centers on the clinical and institutional stakes of deploying AI tools that flag structural heart disease at scale. Our speaker is Dr. Pierre Elias, who is an assistant professor in the Division of Cardiology and Department of Biomedical Informatics here at Columbia University Irving Medical Center, where he practices as a general cardiologist. He is also the medical director for artificial intelligence at NYP. Now, Dr. Elias is going to walk us through a real-world deployment involving over 1 million patients and in the use of AI. And it's exactly the kind of case where ethics moves from abstract principles to everyday decisions with real consequences. Dr. Elias's work is important to consider for many reasons. Opportunistic AI screening promises earlier detection of cardiomyopathy and valvular disease with routine echocardiography for all. But scale can change ethical calculus. And here we have a model that nudges thousands of downstream testing that can save lives, but could also trigger cascades of cost, anxiety, potential false positives or negative results, and capacity strain. It also shifts authority or can shift authority in subtle ways when an algorithm recommends a life-altering test. The question emerges, what do clinicians, patients, and institutions owe one another as we integrate these technologies into healthcare? So we're really fortunate to have Dr. Elias to help us dig into some of these questions with a real example. And so let me just pass it on to Dr. Elias.
Thank you, Dr. Lee. Thank you all for being here. I know this room is new for many of you, the pit, or as I like to call it, the single worst room in Columbia to have a happy hour. But I'm excited to chat with you all, and I really want this to be a dialogue. I think the idea here is we don't have all of the answers, but things have clearly changed, and we have to wrestle with that. And we have to decide, are we behind the times, or are we being thoughtful about all of the history that has told us about how these things can go wrong if we're not very careful? I don't know if any of you saw it this morning. OpenAI actually published a very brief piece saying our conflict or our values are in conflict. Here's what we're going to do about it. And it was specifically about people using chatbots, specifically minorities, and the risk of minorities using chatbots and asking them to be excessively flirtatious. And then if a minority, so someone below the age of 18, was excuse me, I keep saying minority, I keep meaning minor. I was up late with my daughter last night, but minors um, using it for suicidal ideation. And what are they going to do about that? And they've said, we're going to disclose this information to their parents and the like. So these are very real issues. People are using these new technologies in ways that were not anticipated, and they're doing it at scale, right? I mean, if we just think about the number of conversations happening with some of these technologies, this is happening at scale. So I think there is a real need here to kind of go away from the pure theoretical and then to say, what does the theoretical tell us about the actual and the practical that's happening today? And how do we want to address it? Because it's happening. These are my disclosures. So this story started for me around 6 years ago. I was staffing the cardiac ICU overnight and I got a phone call. It was an outside emergency department that said, we have a gentleman here and he's very sick and we need to send him to you immediately. And what had happened is this gentleman had shown up with chest tightness and shortness of breath 3 months prior. And at that time, they ruled him out for a heart attack. And they said, no evidence of a heart attack. The only thing is when we listen to your heart, we hear a murmur. You should go see your primary care doctor, but you can go home. Life got busy. That primary care appointment never happened. And then 3 months go by, and then he has that same episode again, chest tightness, shortness of breath. And he comes back to the same emergency department. This time, though, he's in respiratory distress. And very quickly, they have to intubate him and put him on a ventilator and take him up to their ICU. And they do an ultrasound of his heart, and they find that he has critical valvular heart disease. And so we are a world-leading center in valvular heart disease. And so they're calling me in the middle of the night saying, we need to send this patient urgently to you. I worked on that patient for the rest of the night. But unfortunately, by the morning, he was in multi-organ failure and he passed away later that week. And there was no miss. There was no obvious thing that we should have done different. But the frustrating reality is if we had just known about his disease, he could have gotten a same-day outpatient procedure and he'd be alive today. So this fundamentally taught me that you can't treat the patient you don't know about. And as we think about care paradigms, our patient population in the United States is getting older, is getting sicker, and we're going to have fewer doctors in the next 20 years. So we can't keep doing what we're doing today. It's not only bankrupting the country, it's clearly inefficient, and it's not going to work as people get sicker and we have fewer doctors. So we have to think about different care paradigms. The question is, what is that care paradigm going to be, and who's in control of it? And what are the motivation factors that are going to dictate what care in the future looks like? So I think we need care paradigms that are faster, that are more affordable, that are fairer, and more accurate than what we do today. And this is where I think AI can actually help in significant ways. So we're going to talk a little bit about the discovery of patients, getting patients to diagnosis, and then the actual impact of that in real care. So people like to talk about AI right now. It's very in. A while ago, it wasn't very in. And you kind of hear AI doing everything, right? AI is going to make your coffee. AI is going to drive your car. AI is going to take your kids to school, all of these different things. Where do I think that AI or deep learning, which we're going to use interchangeably, actually makes a difference? I think it's in the domains of imaging and complex language. And the reason for that is if you think about the interpretation of complex language and the interpretation of things like medical imaging or imaging at large, these are things where we have nothing else other than the human brain to interpret those signals, right? The visual cortex is an amazing pattern recognition device, but it is flawed. And all I have to do to prove that to you is tell you that all of these horizontal gray lines on this picture are parallel to one another, even though your brain is telling you they're not. So you have an amazing pattern recognition device, but it has flaws. It is good at picking up certain patterns and not other patterns. For the first time in human history, We have an alternative pattern recognition device that is not the human visual cortex, that is actually quite sophisticated. And so it can look at the same data and derive new patterns and derive new answers compared to what a human can. And that is where I think it's really, really powerful. So we had talked about valvular heart disease. And one of the first studies that we had done was asked ourselves, can we detect valvular heart disease using AI? So the issue is valvular heart disease is too often missed. And the reason for that is because we diagnose it with a much more expensive test, the ultrasound of the heart called the echocardiogram. The issue is because echoes are so expensive, we wait until patients have symptoms. This is the same issue with something like pancreatic cancer. The reason pancreatic cancer has such a poor survival is because we don't have a good screening test for it. So we wait until people have very generic symptoms, right? Like bloating, fullness, satiety, all of these sorts of things. And then maybe after they've seen a couple of doctors, they get a scan. And by that point, the cancer has progressed. So we have similar issues in cardiovascular disease, where the way we diagnose these diseases is either too invasive or too expensive to do on a population level. But we do have common, cheap, ubiquitous tests that exist in healthcare. And so one example is the electrocardiogram. So if you've watched any medical drama and you've seen the squiggly lines in the background, that is an electrocardiogram. That's measuring the surface electrical activity of the heart. And it's the thing that goes beep, beep, beep. So we do over 400 million electrocardiograms around the world every year. You can do a 1 lead electrocardiogram on your Apple Watch. Many people in this room have probably had an electrocardiogram. But I was taught in medical school that you cannot detect valve disease or any of these other diseases from an electrocardiogram. But we asked ourselves, could an AI model do exactly that? Can it do something I, as a cardiologist, can't? And so we built a model and we tested it on over 20,000 patients. And lo and behold, it worked. But if anyone knows anything about AI models, they love to cheat. And so just because it works in a retrospective, held out data set does not mean it's going to work in the real world. And it doesn't mean that there are patients you can actually help with it, right? Patients being missed today. So we said, we want to prospectively test this. We want to go and do a trial. So this is still how we recruit for clinical trials today in 2025. This is the elevator bank right outside of my office. Probably many of you see something similar. Are you 18 or older? You haven't had any recent medical x-rays? I'll pay you $20. Why don't you take a slip of paper and give me a call? This is not a way to find patients who are otherwise being missed. This is not particularly equitable. This is not finding patients where they're at. This is not doing things at scale. And so we had to revisit the entire way that we thought about building these models, training these models, and then deploying these models to find patients who we think actually need help and meet those patients where they're at, rather than expecting them to come up to the 20th floor of Presbyterian Hospital between the hours of 9 and 5. So we have built the largest end-to-end machine learning pipeline at any health system in the United States. We have instant AI deployment at 8 hospitals and 190 clinical sites. We've run live a number of different models and a number of different clinical trials on over 1 million patients in the last 2 years. So every electrocardiogram and every echocardiogram, the ultrasound of the heart, across our entire health system is instantly analyzed by AI, and we record those results. And then on some of those results, we act upon them through clinical trials or clinical programs, and then other ones, we just store that data for the future. So this allows us to run a number of different clinical trials. We just started our 6th and 7th clinical trial using this platform. And so we've really been able to say, let's think about this at scale and create an early detection system for our entire health system. If you take nothing away from my talk, I hope you remember this slide. So Bob Wachter is an old mentor of mine. He's the chair of medicine at UCSF. Eric Brynjolfsson is an economist. He was at MIT for a long time, and he's now at Stanford. And Bob wrote The Digital Doctor, which is a New York Times bestselling book about the advent of digital health. Eric wrote The Second Machine Age, which was an incredible book talking about what is the impact of AI. Eric has spent his career studying this thing called the IT paradox. So there's some industry, and it's due for some information technology upgrade. And everyone agrees the way they do things is really antiquated. We need to bring in new IT. They invest a lot of money. This new IT comes in. And then many times you see no improvement in productivity, which is the metric that economists like to say, okay, that's the one that tells us this was an effective use of resources. And so the question is, why is there not a productivity gain a number of times when you see this new technology come into an industry? And what he has summarized it as, and this was a great paper in JAMA, was there are two keys that are required to unlock these massive productivity gains. So the first is the technology must be sufficiently better than what we do today. And I can tell you AI in medicine in a number of places, that's definitely true. It's the second key that will be our stumbling block, which is we must be willing to reimagine the work itself. We must be willing to reimagine what it means to be a nurse, what it means to be a doctor, what it means to be an ethicist, and how this actually applies to clinical care. And you can say, well, that's all nice and theoretical, but this affects your life. I would go so far to say it is the primary reason for the political instability in the country today. And how did I come to that leap? If you look at the three industries that have failed to reimagine the work, they are the largest three industries. It's housing, education, and healthcare. And we have watched those three things become more than 50% of people's income over the last 30 years. So you can talk all about workers' rights and the need for income to increase. But on the flip side, people are continually getting squeezed more and more for the basic necessities of life. Sending my kid to a good school, feeling like I actually am getting good health care, and feeling like I have a house in a safe neighborhood for my family. I think this is a core part of a lot of the civil unrest that we're seeing today. And the reason for it is these are three industries where, through a combination of lobbying, government regulations, and a number of other things, we haven't seen much reimagining of the work itself. What is required to zone a location for building a house or multifamily housing looks very much the same now as it did 30 or 40 years ago. And what it looks like to be a doctor today, while different in some ways, you could take a doctor from 100 years ago, walk them through the hospital, and they would know all of the locations. That's the operating theater, that's the clinic, that's the hospital ward. They would understand there are nurses, they'd understand they're a doctor, they'd understand what it is. But compare that to something like software engineering. What it means to be a software engineer now versus 10 years ago is radically different. And what it means compared to 20 years ago is not even in the same ballpark. So it's not to say that certain industries are creating more net benefit for society, but it is to say we have to think about how we allow these industries to reimagine the work themselves. And what that also requires is us to really deeply think about what are the forces at play. So if someone goes and reimagines work to, the work itself for healthcare today, they'll probably say, well, doctors shouldn't be in charge of X, Y, and Z. We should have more administrators. We should have more people who are making X, Y, and Z decisions. And you can ask yourself, okay, is that the right question? Is that the right answer or not? But the real question here is, what are the market forces at play? And how do we start thinking deeply about, are those market incentives aligned with the benefit of the healthcare of individuals and the country at large? And this is a problem that has existed in our country from the very first time that we created insurance, from the very first time we created a hospital, and is now kind of rearing its ugly head again. So this is the question that I've been obsessed with for the last 5 years. Of all the patients with an EKG and no echocardiogram, who needs an echocardiogram? So if we take all the patients getting the cheap test, who needs the more expensive test? And could we create an AI-based biomarker to screen patients for cardiovascular disease? And so we built an AI model that does exactly this on over 800,000 ECGs and echocardiograms from 150,000 patients. And it was the first model ever to detect all forms of structural heart disease. So there's basically 13 different diagnoses that we make that we call structural heart disease. And it's the reason we order an echocardiogram. And we just recently published this paper in Nature. If any of you are researchers out there, I think you will agree with me. Society does not care about research. That is something we have accepted. We try to convince them otherwise. This was maybe the first time I really felt like society cared about our research. It was viewed 500,000 times in 2 weeks. I went on CNN to talk about this. It was the front page of the science section in France. And I think there was a moment where people said, is this an actually useful version of AI? Or is it just taking my picture and turning it into like a Studio Ghibli version of myself? I think people have been looking for, well, is this going to really help? So the impact was pretty staggering. It was validated 11 hospitals, 4 health systems, 2 countries. We then ran it on 85,000 patients and followed those patients for a year. What we found was The model not only had excellent positive predictive value, but half of the patients that the model thought were high risk don't go on to get an echocardiogram as part of routine clinical care. So we're missing up to half of the new structural heart disease diagnoses that are showing up in our health system. We ran a prospective clinical trial, and we found that the AI model performs just as well prospectively. And then we had to go head to head against 13 cardiologists reading over 3,000 EKGs. And we asked them, a yes, no question. Does this patient have structural heart disease or not? And so the cardiologist accuracy was 64%, and the AI model was 78%. And so it's a yes, no question. So random chance is 50%. So I, as a cardiologist, am as far away from random chance as I am from the AI model. And, myself and my co-creator, we recused ourselves from the results, but we were no better than the other 13 cardiologists. So we disagree with the model and we're wrong. Okay, cardiologists are pretty arrogant, so maybe it's just a cardiologist problem. Maybe the radiologist will do better. So we built an AI model looking at chest x-rays to try and find early diagnosis of heart failure. And we found basically the same exact thing. We found that this AI model outperformed 15 radiologists from around the country in predicting who did or didn't have early signs of heart failure. And just a few years ago, we were saying that these AI models were maybe 80 to 90% as accurate as human experts. But now we're seeing these AI models exceed human experts at certain tasks, depending on how you structure it. Okay, so we looked at all of these patients who have EKGs. We got them to the echocardiogram. Problem solved, right? Go team. Well, I had a patient come to me last year, and I said, you need an echocardiogram. And he's like, Doc, don't worry. I just got one done at another hospital a few weeks ago. I'll bring you the results. And he brought in the results, and these were the results. And I know no one in the room reads echocardiograms for a living, but I posted it on Twitter, and Mark's an interventional cardiologist down in Virginia, and I think he said it perfectly. This is not what we would call a high value read. And so we still have this problem of there's huge variation of the downstream diagnostic tests or of human interpretation on those tests. So we asked ourselves, well, could an AI model help us with what we think is the most complex task on interpreting echocardiograms or heart ultrasounds, which is the valvular regurgitation? And it turns out it has 96% agreement with academic labs. And then the 4% of the time that it disagrees, half of those times it's right and the original read is wrong. So this actually led to the first AI overread of a cardiologist, where the AI disagreed with the cardiologist. It was blindly adjudicated by other cardiologists. And they said, yeah, we missed the severity of this disease. And then that patient had to come back in and ended up getting a mitral valve replacement, a major surgery that they otherwise weren't going to get. And so this is the world's first time of an AI overreading a cardiologist, disagreeing with them, and it leading to a mitral valve replacement. And we presented that at American Thoracic Society earlier this year. The last disease I want to talk about is the one that I think is going to be most interesting for our conversation. So did anyone here read the Wheel of Time books growing up? No. I'm going to just stop asking that. I feel like I've asked that at like 10 lectures. I thought they were more popular than they are. Well, cardiac amyloidosis is this rare cause of heart failure. And the story of this disease was very sad for a long period of time. Patients would develop heart failure. They'd be getting sicker. They wouldn't be responding to therapy. They would get sent to like an academic center. They would see a number of different people. They would have to get like an invasive biopsy of their heart. And then they would finally get to a diagnosis and they would say, great, what do we do about it now? And they'd say, I'm so sorry, there's nothing we can do for you about it. And patients would die from this disease. What's changed is in the last 10 years, we've created a non-invasive way to diagnose the disease. And that was invented here at Columbia. And we wrote the first New England Journal paper of a medication that has a mortality benefit for this disease, tafamidis. And this is a medication that you're not otherwise going to stumble upon for these patients. You really have to know that they have this specific disease to give them this specific drug. And it's expensive. It's $150,000 to $200,000 a year. But it adds 4 years to people's lives on average. So we said, we think that there's a bunch of patients out there undiagnosed with this disease. Can we find the needle in the haystack? So we built an AI model. That AI model had good performance on a retrospective data set. And we did the same thing, which we said, hey, we want to apply this prospectively. Matt Maurer is kind of this world-leading expert in cardiac amyloid. He's a mentor of mine. And he's like, listen, I know that this disease should have a preponderance in Black and Caribbean Hispanic patients. But all of my patients in clinic are like white people from Jersey or upstate New York. What's going on? I was like, that's interesting. Let me look into it. So we looked at what's the relative proportion of white, Black, and Hispanic patients who show up at our doorstep. It's about 46% white, who get the cheap test, the EKG, again, around 40, 45% white. And then who gets an echo, slightly more expensive test, about 50% white. Who gets a PYP scan, which is the advanced diagnostic testing we do for cardiac amyloid, and it's 80% white. So the upshot here is the people we send for advanced diagnostic testing are twice as white as the general population we care for. So everyone talks about, is AI biased? Is AI creating a lot of bias? I say there's bias in care today, unintentionally, and can AI help us with that bias? So we asked the AI model, of these people who we consider to be potentially high risk for the disease, who do you think is positive for the disease? And the AI model said, well, here are the people I think you should bring in. And their relative proportion was 54% white, 16% black, 31% Hispanic. So it looks a lot more like the patients who show up in our health system than who is actually getting referred. So AI can actually potentially correct bias when used correctly and appropriately. Okay, so let's get to the meat of it. We said we want to do this. We want to do the first cardiac amyloidosis discovery trial using AI. We want to screen a bunch of patients for this disease and see if we can figure out who should come in for a PYP scan and put them in for treatment. So give you an idea, here's the baseline. So if you look at how many scans we do a year at NYP, this is from 2023, we do about 830 scans. We diagnose about 120 people. The rate of positivity is 14%. So we built this AI model, and then to be included in the clinical trial, you had to be someone who is not otherwise being considered for this disease. So the health system had completely missed you. You have seen a cardiologist, but no one thinks that you need a PYP scan. You have not at all been considered or evaluated for this disease. On top of that, you have to be a candidate for treatment. So you can't be someone where you have life-limiting disease where we would not put you on treatment. They all had to be people who we put on treatment. And so we found 256 patients that we wanted to put in the scanner. And we were able to get 50 of them into the scanner. And I'll talk about that in just a second. So what was the result of those 50 patients we were able to get into the scanner? So 48% were positive compared to 14% in historical control. So compared to a cardiologist referring a patient for this test, we had 3 times the rate of positivity. We increased the total number of patients diagnosed with this disease by 20%, and we only increased the number of scans we did in the health system by 5%. So these results just genuinely astounded us. We were not expecting them. So I said, well, we had 250 people we wanted to put in the scanner, but only 50 got in the scanner. Well, what happened? Well, 50 of them, the doc just literally never responded to repeat messaging. Then 30 times, the doc said, no, you can't reach out to my patient. And then 70 times, the patient declined. One of the biggest reasons, I don't want to be a guinea pig. I don't know what this is about, all of these sorts of things. So there was a real need to build trust, but also there was just a real issue with patients or messages being ignored. And at Columbia, we don't have the right to reach out to patients directly if their physician does not. This is not how it is at many of our peer institutions. At the University of Pennsylvania, at Vanderbilt, at Stanford University, at Cleveland Clinic, if a physician does not respond to a message within a timely amount of time, a centralized system can take over and reach out to the patient directly. But at Columbia, no such ruling has been made. So we essentially think that we could have doubled the number of people diagnosed. And these patients remain undiagnosed and untreated, which means that they are likely to potentially die from this disease sooner because they will not otherwise be put on treatment. So this is the ethical conundrum. I'm going to stop there. I don't know if we need to. Is this the right time to stop, or should I talk about the last project? Sure. Okay. I'll go over this last project. So I had told you a little bit about Echo Next, that AI algorithm, which tries to figure out who should get an echo by looking at their EKG. So we're running the Cactus trial. This is the largest cardiovascular AI screening trial in the country. Basically every patient in all of our emergency departments is going to have their EKG screened by the AI model. If they have a high-risk EKG, no prior echo, that triggers us to evaluate the patient. First, we ask the physician, hey, do you want to order an echo on that patient or not? And the physician can make a determination. It turns out like myself, docs read between 0 and 0% of alerts. So we take over when they don't respond to the alert. And we say, okay, we're going to evaluate the chart, make sure that this patient should get an echo. We think it's clinically appropriate. And then to minimize financial toxicity, we are paying for all of the echocardiograms. And so we coordinate getting them to the echo. And if their echo is positive, we coordinate getting them to a cardiologist. We just completed the pilot trial, and the results have been extremely compelling. We're very excited to start the randomized controlled trial. To put it into context, through the EchoNext program, I ordered more echoes than any single provider at NYP over 6 months. I am now numero uno. I had the highest rate of positivity of any provider. So not the total number, but the highest rate. I'm the Steph Curry of ordering echoes now. I'm the equivalent from a productivity standpoint of the 5 highest RVU generating cardiologists at Columbia, and I don't have a clinic. This is the only time I'm ordering echoes or when I'm on inpatient service. And we never met any of the patients before ordering the echo. This is a part of our work stream that is clearly and fundamentally broken. This is clearly a way that we're going to proceed with practicing cardiology and changing the front door. The ability to get patients correctly to referral care is nearly impossible and is only getting worse. If you show up with a symptom like shortness of breath, you'll have a 2-month wait to see your primary care doctor. Then, they'll say, well, you should see a cardiologist. It'll be a 4-month wait to see the cardiologist. Then they'll say, well, let's get an echo. And then it'll be another month and things like that. These patients are showing up in our emergency department and otherwise being completely missed. And we're saying, nope, that patient needs an echocardiogram. We get one within the next 2 weeks. We see that they have a positive diagnosis and they see a cardiologist within 2 weeks' time. And it has been profound, the impact that it has had. These patients are vulnerable. And what we're seeing is they're being told, yeah, the reason you passed out is vasovagal. It's not cardiac in nature, but they actually have heart failure, severe heart failure. Or a patient who came in short of breath, 42-year-old, was told it was his asthma. They sent him home with an albuterol inhaler. He actually had severe valvular heart disease. So this has led to multiple surgeries, numerous treatments, and this is, the randomized controlled trial that we're now running. So AI-based opportunistic screening is going to fundamentally change the way medicine is practiced. I think we are already seeing the development and validation of these technologies, but this last mile problem and how we interface with the patient is the fundamental question. We have to reimagine what it means to practice medicine if we're going to be able to help these patients. We have to reimagine that the relationship with the patient and their clinical care goes beyond the 10-minute visit that they have with a doctor and becomes about the wraparound services that we have created for these patients so that we can take the best possible care for them. There's clear evidence that we've been failing patients. There's clear evidence that there's a way to move forward that we think is better. And the question is, how do we create appropriate safeguards around it? What are the ways that this can go wrong? And what do we have to prove in order to do this? So thank you so much. And looking forward to the discussion.
Hey, I know we have folks online who might have questions, and I want to encourage them to put them in the Q&A box. But and folks in the room, please raise your hand if you do have questions. Let me start off on your last point. I think a compelling point around reimagining work, reimagining clinical care and how that's necessary. And I was struck by your study where you had patients and clinicians basically refusing to go forward, right? And we're an institution where you can't reach out to the patient. You have to go through the clinician. So, this raises questions, I think, around how AI may be undermining clinical authority, that we may have to rethink the role of the physician and start looking at AI as the physician. I think some people have posited that as a threatening proposition. What do you think about that?
It's really hard. Medicine historically has been somewhat, paternalistic or maternalistic. And not always to the disadvantage to patients, right? Trying to protect patients is important. The flip side is like, does this patient belong to this physician? Does this patient belong to this department, right? We've gone to recruit patients like in the emergency department. They're like, no, this is an ED patient. You can't recruit patients here, right? No, this is my patient. Does the patient's data belong to the health system or does it belong to the patient? These are very hard questions. Like I don't pretend to have an answer. And what's clear is either direction you go, there's going to be missteps, right? So either direction you go, you can either say, this is someone we could have otherwise helped, but we missed the opportunity because we were too restrictive in the ability to communicate with those patients. Or you're going to have missteps where we say, hey, this was something that was predatory or something that the patient did not fully understand that they went forward with. I think, real challenge here is it comes down to, is it even appropriate for that physician to be making a remark about that disease process, right? So like if you're a urologist, are you the one who should be making a decision about the patient's cardiac care or not? And there's just so much variation in how doctors want to respond. And so like if you try to do it in like a fully individualized case by case basis, it can be hard. What we've seen at Stanford is basically they give the physician 2 weeks to respond to the message. And they can decline. And then if they simply don't respond to the message for 2 weeks, then they take over and they say the benefit outweighs the risk. I think the really key thing here, though, is the benefit has to outweigh the risk. And if you're truly in the first stages of investigation, then you have to be a little more cautious. But if you've started to establish some degree of evidence, right, even from the early parts of the study, that this indeed the benefits outweigh the risk for the patient, then I think there has to be a conversation. And it may not be that every single study can automatically reach out to patients, but at the very least, we should have a way where we say this was evaluated. There's clear evidence that the benefit far outweighs the risks. This is being done in an appropriate way. They're going to report back what their findings are after a year, and be able to proceed with the study. Otherwise, I mean, I think like, the patients who are the ones most likely to lose out are the ones who are least connected to care, right? People talk about, in my chart, there's this consent to contact button where you can say, I consent to contact from research. The patients we're helping, many of them are over the age of 60. Think about the average Columbia patient who's over the age of 60. They have no idea what my chart is. They do not have a my chart. So that's not going to work for those patients who we think are potentially most vulnerable. So I don't think there's a single perfect answer, but I think there does have to be at least some way to monitor this and say, okay, this is one where we agree the benefits outweigh the risk.
Well, so let me push a little bit and say, so in terms of reimagining then, we have a system, a complicated healthcare system. We think that there's going to be benefit because for follow-up. Who is ultimately liable? Who has the responsibility to ensure that the patient is accessing this type of diagnostic?
That's a great question. So the first is, okay, do you have an obligation for the patient to access the diagnostic? And if it's not guideline recommended, you're under no obligation. Now, let's say you find something. Are you under obligation to do something about that? That is where I think the IRB is the most helpful, right? And that's where you really want the IRB to say, okay, what are all the potential things you could find, right? You're going to go do an echocardiogram on this patient. Could you find something that doesn't actually matter but leads to an unnecessary surgery for the patient? Are you going to find something that's really bad, but then the patient doesn't follow up with treatment? And this is something we have to do for every clinical trial, whether you're talking about AI or not. You have to say, like, as soon as you involve yourself in the patient's care, what are all the potential outcomes and what are you going to do about them? And so again, comes back down to, it's not that there's no risk. It's one, are you foregoing consent because you believe that there's minimal risk criteria and the IRB agrees with you? And so like the Cactus trial meets minimal risk criteria. And so there's no patient consent for that study. Or with the amyloid study, that is radiation. The PYP scan involves radiation. And so we consent every single one of those patients. But we want to make sure that those patients are very likely to end up on treatment. And what we show is, 91% of the patients we diagnosed ended up on treatment, which is far higher than patients who are otherwise diagnosed as part of the health system. So if you can show that you're outperforming routine clinical care, you're finding other patients. So I think it's reasonable to have relatively high standards of, are you generating the right evidence? Are you thinking about what the outcomes are? And are you doing something about it to the benefit of the patients who are actually involved in the study? Then you're okay. But you've got to really do those. Like, we don't have to reinvent the entire wheel with AI. Like, we figured out a lot of these important things through decades and decades and decades of running clinical trials, of having the FDA regulate a number of things and stuff like that. And I think a lot of it does apply to AI. And then there are places where we do have to rethink, what do we do next and all of that. But a lot of it, I think we have a really clear roadmap that is appropriate, which is, hey, this is changing clinical action. The last thing I'll say, though, is if you look at the AI companies that are the largest and making the most money, they're the ones that are completely unregulated. It's the AI scribing companies and the revenue cycle management companies. So there's been $900 million of investment just in AI scribing technologies, just in the top 5 companies in the last 3 or 4 years. That's probably the same amount of investment that there's been in everything else, as far as kind of like digital health, AI, all of those sorts of things. And so those companies are growing massively. And part of the reason they're able to grow massively is they're completely unregulated. So is regulation actually working the way that we want it to? Is it not? I think regulation totally failed us with electronic health records. I think the few incumbents at the time said, yes, we want to be regulated, and they turned around and they shut the door on them. And it was the same thing in the telecom industry. And it's why we all have crappy internet and we only have one option. So there are definitely times where regulation, I think, has harmed us. It's obviously a more complicated story, but like this is a real challenge here, which is regulation is important for patients, but like it's had undue effects depending on how it's implemented, and we've all experienced that through electronic health records.
Are there questions? Oh, I see 1, 2, actually 3. Good.
Yeah, thank you so much. Yeah, I wondered if you could speak a bit to how what you see as the sort of mechanisms for moving us forward on these questions around regulation. So we're failing on the regulation front. How do we, what are the, and you can say that this is outside of your wheelhouse if you want, but I'm curious to hear, is that how do we move forward on that?
I think a lot of times these things are ultimately driven by political agendas, for better or worse. And so we have to ask ourselves, like, what is the agenda? So I would say Rob Califf, who was running the FDA right before this. So I'm a Duke guy. I was at the DCRI. Rob is now semi-retired and takes all of his meetings from a lazy boy chair. But I think Rob had a really good balanced vision, which is you got to do the work, you got to put in the evidence, but like the lifeblood of, our medical industries is the innovation that we create. It's the only reason that the whole medical infrastructure hasn't gone completely under yet. Again, it's a complicated story, but we are the world leaders in medical innovation. We've created many of the therapies that exist. So you gotta curb some of the worst habits of these companies, but you've got to make it so that they feel like innovation can exist. I think it's still too early to tell like what that looks like in the current FDA. I'm personally going through my first like FDA approval process right now. So I received breakthrough designation earlier this year, and now I'm submitting 510(k) approval. And literally, I'm getting on a plane later today, and like while I'm at the airport, I have a meeting with the FDA, and the guy I'm meeting with is like, just a bucket of daffodils, just real fun. But he's the guy who, if you guys saw, Apple Watch now has something that'll tell you about high blood pressure. So he's the guy who approved that at the FDA. And so we've been meeting regularly with him about these technologies. I think it's still too early to tell where's the FDA headed. I think you need to have real dialogues. You need to have places where industry, academia, and FDA are actually talking about it. But at the end of the day, you can have all the conversations you want, but if there isn't strategic alignment with the political factors at play, it's not going to happen. And so the question just becomes, what does that look like for the next 3 years? And if it's not now, how do you get ready so that if something does change 3 years from now, you're ready to go? That would be my take on it.
One more question from the audience. I also have a couple from the online attendees.
Hi, thanks so much for your talk. I had a question kind of piggybacking on that and alignment of stakeholders, I guess I would say. You have done so much work through our health system with cardiologists and other clinical care providers, and I wonder if you could talk about any kind of alignment activities you did with the clinicians and how that went and what you did.
No comment.
Oh,
It's so hard. It's so hard. I consider myself like a reasonable person, but I've definitely become way less reasonable as the years have gone on, because you want to do something, you have a real vision about it, and you just hear no so much. Not no because, not no unless, you just hear people who say, that's not the lane that I'm in. That's not what I currently do. That's not my job description. So no. And you have to constantly find a way to get to yes, where you feel like it's still ethical and appropriate and you're navigating it. And so my mentors, gave me this picture frame, and in the bottom there's a quote. And I didn't know at the time why they gave me this quote, but I think they had an idea of where things were heading, which says, success is stumbling from failure to failure with no loss of enthusiasm. Um, and I think if you want to do this, you have to be ready for a world of hurt. You have to be ready for no one to care, for people to be actively annoyed. When I first started doing this work 6 or 7 years ago, I just needed access to the data from my own department, and I would reach out to the cardio IT administrator, and I emailed him every 2 to 3 weeks for 6 months and never heard back. And you have to be realistic about how important is the thing that you're doing, how willing is the institution to come about it, and are you playing for the long game? Like, is the thing that you want to do, something that you think it has to exist in the world? Are you irrational about it? Do you feel like it has a really, really big impact? And so, we just had a big meeting. There's a lot of these kind of cardio initiatives across the institution. Maybe $15-20 million has been invested across Columbia, NYP, Cornell, and things like that. And I said, like, a big part of my job is restraint. A big part of my job is saying there's like 3 or 4 things we can really pursue for the next 3 years. And those things have to really matter, and we have to do those things really excellently. But it's so hard. And so I think the only thing you can do is show people that you really believe in this, be a great storyteller, convince them that this isn't about you, that this is about the benefit of society, the benefit of patients, the benefit of the health system. Be creative. Don't take no's as an automatic no. Obviously, don't be devious, but like find, have a plan B through L, and then go at it. And then, if you're determined, I think you can make progress. But it's a painful route. I think to change anything is hard. To change healthcare is really hard. To change a big, academic health system that's very confident in the way that it practices medicine, it's very, very hard. But if you believe in it, it's worth it. And so you got to just start with the problem that genuinely matters to you.
So, can I push on that a little bit? I'm wondering, is this a problem about, that we could see historically, where clinicians are resistant to change and new technology, or is there something specific about AI that is throwing up the challenges? And also, I guess I want to hear a little bit more about value alignment, in terms of both patients and clinicians wondering, is this about efficiency and cost, or is this about the patient care? Or is this about something else, losing kind of power and authority? I don't know how you think about that. And if there are any historical analogies we can point to where things have been proposed and there's been resistance to the integration.
Totally. So in general, physicians have lived an experience where someone comes and tells them, we're changing this thing, and it's literally never for the benefit of the physician, right? Hey, we have a new EHR, we have this, we have that. It never makes the physician's life better, right? And so I would say most physicians have experienced most forms of change that may be better for the health system, may be better for the patient, but oftentimes is a net neutral or a net negative for the physician. And then the few times where it is a net positive, they say, well, it's expensive to give you this thing, and so you need to go see more patients and things like that. So I think physicians come from a place of suspicion about many changes because the lived experience of those changes has been one where it's often not for their benefit. It's also a question of like, how much is it for the benefit of patients? You can get doctors to do things when it's just like obviously clearly beneficial to the patient, but oftentimes things are much murkier than that, right? Is there real clear definitive proof that this is going to help? And the like. I think Epic is better than Allscripts, which we had before, but is there real clear definitive proof that like it's saved patient lives or a number of things like that? It's very hard to say. What we do know is we spent $1 billion on it. that we weren't going to be able to spend some other way. And there was a second part to your question.
Yeah, well, for the purposes of time, I do want to ask you this question from an online participant. So I'm gonna use their words. So when dealing with screening, where the patient is not opting in with AI interpretations, how do we draw the line where we have patients having health forced upon them? In particular, I'm wondering where we deal with people who have conditions that might be weaponized against them in terms of employment, insurance, or disability claims. Yeah.
It's really tricky, right? And you can have the best intentions for a patient, but you can realize there are these things out of your control. I think this is where there has to be some degree of consensus by committee. And what I mean by that is we have to say, listen, there is a really clear established benefit to this patient knowing it. Is there a risk? Yes. What do we think is that risk? How likely is that risk? And how likely do we think the benefit is? And then we have to proceed. I think if you overly fixate on the risk component, it becomes even harder to innovate in medicine, where it can be really, really challenging. We are one of the world leading valve centers in the world. And we were one of the people who helped create TAVR, which is this form of deploying a heart valve that doesn't require you to crack open the chest. Those first 100 cases went poorly because these were the highest risk patients. These were patients who you couldn't otherwise crack their chest. And so they were going to die. It was compassionate use. And it was saying, this is a technology that is going to work. It is now one of the most common cardiac procedures that we do in the world. It has been shown to have huge mortality benefit for patients. And it has opened up an entire new field of transfemoral and transcutaneous valve replacements that didn't exist before it. So this is, I think, just like a fundamental challenge of, okay, what is the risk tolerance? How do we have a reasonable discussion about it? And how do we look to what's happened before? I think the risk scores are better now than the stuff we use in day-to-day practice. I think most of the risk scores that we use to decide clinical care today are actually quite bad. You see it in the actual numbers as far as what is the receiver operating characteristic curve and those sorts of things. But it's just because they're what we've used to date that we continue to use them. But there are very real risks, and we have to accept that if we move forward, we're going to make certain mistakes. And we have to say, well, how severe would that mistake potentially be? Do we at least understand and acknowledge it? I think to pretend like it doesn't exist is not good. I think to not move forward at all and make healthcare better because of those risks is also not fair to patients.
Okay. Yeah. I mean, we've been talking a lot about clinician trust, and I guess trust and trustworthiness of the institution, and from the perspective of the patients is very important. Okay. I think we're going to have to end, but I want to make sure that you know about our next ethics grand rounds, which is ethical challenges in the evolution of xenotransplantation. We'll have Dr. Brendan Parent from NYU here. But I really want to thank our speaker today, Pierre Elias. He is a thought leader in this space, and we're really thrilled that he could join us today. So thank you very much.